Good evening. Thank you, Sai. In all our conferences, you'll find many talks or even actually sessions on complications of multifocal intraocular lenses and also how to deal with unhappy patients. But you'll never find a talk on how to deal with an unhappy toric IOL recipient. So this is because toric intraocular lens is very effective in correcting astigmatism. And among the various choices for correcting astigmatism in a cataract patient, toric intraocular lens is the best, and toric IOLs are not associated with visual disturbances. See, with this degree of astigmatism possible in cataract patients, there is definitely a definite need for toric IOL implantation. And this is what we did in this old patient with hard-brown cataract. She had an astigmatism of 2.72 diopters. As always, in this patient also, for toric IOL implantation, special attention was given to 3 key areas: IOL calculation, marking of the eye, and proper alignment of intraocular lens. Immersion A scan was taken and K reading was measured using auto and manual keratometers. Toric IOL calculator was used to determine what toric IOL model is to be used. It was SP toric T6, and the optimal axis was given as 40 degrees. 0 to 180 degree was marked in the sitting position. So the marking on table was done based on the 0 to 180 degree marking, and routine phacoemulsification was done. It was this is what care that you have to take during implantation of a toric IOL is that so you have to align the intraocular lens properly after putting the IOL in the back, and the problem occurs while washing the viscoelastic. So while washing the viscoelastic, you have to take care that it doesn't go away from the indented axis, and even if it goes away from the indented axis, at the end, you have to carefully rotate it so that it is finally in the indented axis of alignment. And finally, you have to tap down the IOL on the capsular back to seat it on the posterior capsule. Postoperatively, so this is, so you can see everything was done properly. And postoperatively, you can see that the patient has a 2.5 diopter astigmatism at 70 degrees. So it was a 2 point, the marking was to be done at 40 degrees, everything was done, and postoperatively, we had this result. Sai, what could have gone wrong?
IOL calculator that you're using, and what is the biometry that you're using?
See, it is an immersion scan. We don't have an optical biometer, and K readings, both manual and case.
The optical coherence biometer with the Barrett's toric seems to give much more accurate results as far as IOL power calculation is concerned, but I'm not sure whether that is the real cause for the major fracture here.
See, as I said,
what are the post-op photographs?
I'll
yeah,
come to
yeah.
that. In a toric IOL, we will not get the intended result in toric intraocular lens if the positioning is not proper. Say this could happen if there are errors in reference marking, axis marking, or the placement of IOL on table. But IOL in this case was exactly placed at 40 degrees. So absolutely no error in placement of the IOL. So even if there was an error in the placement of the IOL, toric IOLs, we can easily rotate it back into the intended position. You can take back the patient into the OT and do it. It's not a huge problem. But precision of toric IOLs basically depends on the preoperative precision, intraoperative precision, and intraoperative issues, like if the patient had a PC rent or bone burns and all. So if you can really place the intraocular lens properly. So this is what determines the precision of toric IOL. But whatever is the cause of the error in this case, we have to manage the case properly. So for this, we use the toric results analyzer. I went to Astigmatism.fix.com. This is developed by John Bedall and David Harton. It helps to determine if a previously placed toric intraocular lens is ideally aligned. So it compares the current location to the current manifest refraction and determines if rotating the toric IOL would reduce the residual astigmatism. Determines the amount of rotation and the expected residual refraction. All these values have to be entered. So all were entered. And finally, it said rotating at 24-degree clockwise will minimize the astigmatism. So nothing else to do. So we posted the patient for IOL redialing, and postoperatively, you can see on AR there is a minimum 0.5 diopter cylinder, and she read 6.9 with minus 0.5 sphere. So problem was solved, but still, what could have gone wrong? See, were we supplied a wrong IOL? See, that because everything is right. Imagining that your all calculation and everything is proper, IOL is aligned properly, we supplied a wrong IOL. Or was there a clerical error? Did the optometrist enter the measured K reading wrongly? So probably this is what happened. See, this is the preoperative K value, and this is the postoperative K value. See, my incisions don't make this much amount of change in astigmatism. So you can make errors in toric IOL implantation this way also, but still we could manage it properly. That is the beauty of toric intraocular lenses, and that is the reason why you won't find any talk on managing unhappy toric intraocular patients in AIOC 2019. Thank you.